कितने लोग आए देखो I'm Dr. Lubna from Gynae Ops Department, Unit 2. Today's topic is obstetric emergencies. So it's a very interesting topic, a long topic, although I've tried to make it short so that you can pick up the important things. And the objective of this lecture is to know what is the definition of emergencies and what are the different type of emergencies we encounter and how can you deal these emergencies, their definition and their management. So by the end of the lecture, you'll be able to understand how to deal with these. So let's start with the definition. An emergency is an occurrence of a serious and dangerous nature event which develops suddenly and unexpectedly, demanding immediate attention. So it's an emergency. The causes may be maternal or fetal. In maternal, antepartum hemorrhage, postpartum hemorrhage, amniotic fluid embolism, pulmonary embolism, preeclampsia, eclampsia. In the fetal, umbilical cord accidents and shoulder dystocia. The principle of managing obstetric emergencies. There are 3 A's. Number 1, avoidance. That when you are having a patient in your antenatal booking or in the antenatal OPD, you should try to avoid or try to pick up the thing. That means either avoid the event or anticipate. That anticipate if a woman has got a big baby, good sized baby, where you think there is a chance of shoulder dystocia, you should anticipate before that and manage it. Or if a patient has got low-lying placenta, you should always inform her, tell her the date and give her an date of elective cesarean section. Or if a woman has got high blood pressure, she has got poor compliance, you should admit her and control her blood pressure. So avoidance, anticipate and manage risk, adopt good obstetric practice. Number 2 is assessment. Whenever a patient has come with some emergency, immediate assessment is very important. And there's need of ABC, that is airway, breathing, and circulation. So always find for help. Whenever you assess this is an emergency, please call for the help. This is very important. You alone cannot deal with the emergencies. You need helping hands. You need your juniors. You need your house officers. You may be needing other staff as well. So first of all, airway, then check for the breathing, and for the circulation is the maintenance of IV line. Then obvious causes should be ruled out. The third A is the action. You have to take immediate action. Resuscitate patient, maintain IV line, give her oxygen, and remove obvious causes and manage other causes. Obstetric hemorrhage is one of the most common cause of maternal death. This is one of the most important emergency. So any blood loss from the vagina, which is greater than a shoe during pregnancy, or excessive blood loss after the delivery is obstetric hemorrhage. Obstetric hemorrhage blood loss is almost always maternal. An unusual exception is vasa previa. So whenever the patient is bleeding, always think this is maternal loss. Exception is vasa previa. Vasa previa is very rare, where blood vessels on the fetal surface of the placenta are ruptured during ARM or during spontaneous rupture of membranes, and you find that all was well and suddenly you find that the baby is gone into distress with a severe bradycardia. So this is again an emergency. If you will not pick, the baby may die in utero. So that is vasa previa. Antepartum hemorrhage, another way we call it APH, which includes placental abruption, placenta previa, and vasa previa. It complicates 2 to 5% of pregnancies. So abruption, previa, and vasa. So main 2 are the bleeding from the maternal part, and vasa previa is the bleeding from the fetal part. So how to differentiate between these 2? Placenta previa is always think patient will come to you, that is during the antenatal period and she will say that she is having bleeding or spotting, but it is not associated any pain. But in case of placental abruption, it is always painful. She will say, I was having pain and then I started noticing some bleeding. Patient in placenta previa may be less distressed. Abdomen will be soft. In case of abruption, patient will be distressed because she's having pain, contraction. So she will not even allow you to touch her abdomen. So when you touch her, you will find distense, tender abdomen. In placenta previa, because placenta previa means the placenta is in the lower segment. Normally, the placenta is in the upper segment. That is a normal situation posteriorly. So, previa means the placenta is lying in the lower segment. There are categories, major and minor. So, whenever there is major placenta previa, then it may lead to bleeding. Or when the placenta is occupying the lower segment, the presentation of the baby may be abnormal. Either the baby may be, the head is free, or the baby is in transverse lie. In case of placental abruption, always remember the placental abruption means is the partial detachment of normally situated placenta. That means the placenta is present in its normal place, but it is partially detached or is disrupted due to any event. So that way, in this case, the fetal lie will be normal. Even the head may be engaged, not free floating, but in case of placenta previa, because the lower segment is occupied by the placenta, the head may be free. CTG is normally, is usually normal in case of previa, unless until the patient is heavily bleeding. In abruption, the CTG may be abnormal, or sometimes if the abruption is massive. In case of mild abruption, the fetal heart sound may be present, but in cases of massive abruption, the fetal heart sound are absent. But in case of placenta previa, the fetal heart sound are usually present. Placenta previa may not be associated with high blood pressure, preeclampsia, but in case of placental abruption, always remember this may be a sequelae due to high blood pressure, or due to uncontrolled blood pressure, or due to preeclampsia. Those women having PIH and not taking their medicine properly may lead to placental abruption. So this is one of the risk factors for the abruption. In placenta previa, no coagulation defect is found initially, but in case of abruption, when the patient presents to you, she already had internal bleeding, because abruption can be concealed or revealed. Concealed means maybe hidden, or the placenta is separated and there's collection of blood inside the abdomen. The patient may not be knowing that. Until unless the bleeding is obvious or she has severe pain, then it only they present with us in the emergency. So coagulation defect may occur early in cases of abruption. The postpartum hemorrhage is hemorrhage or excessive blood loss more than 500 after delivery in the first 24 hours, or more than 1 liter after cesarean section during first 24 hours. So that is called primary PPH. Again, it is also one of the commonest cause of maternal morbidity and mortality. Secondary PPH means if the woman has heavy bleeding, she bleeds after 24 hours till 6 weeks, that is procuring, that will be called secondary PPH. The most common cause of primary PPH is uterine atony. That is, atony means the uterus is relaxed. So 90% of the cause is uterine atony, the uterus is relaxed. So when the placenta is delivered, the uterus, the muscles of the uterine muscles, they contract and they close the blood vessels surrounding it. So that leads to contractions. That is, atonic uterus is contracted. So when you feel it, you can easily say that the uterus is well contracted. But in few cases, in certain conditions, uterus may remain relaxed, such as prolonged labor, such as macrosomia, such as in case of general anesthesia, in case of hydramnias, or in case of multiparas, the uterus may not contract so easily. And even for the contraction of the uterus, we give oxytocin after the delivery of the fetus. That is the third stage of the labor. So if you find that uterus is relaxed and patient is bleeding, so that is the cause of the due causes to uterine atonia, which is present in 90% of the patient. Number two, if you find the uterus is contracted, think of trauma. Maybe the patient has got trauma. Maybe the cervix is lacerated or is torn during delivery, or there is vaginal tear, perineal tear. So always try to find out any tear. Sometimes the tear may be missed, or sometimes the apex is missed and the patient keep on bleeding. Number three, retained products. So sometimes few parts or few placental pieces may remain inside the uterus, that is retained products, and that can also cause bleeding, primary PPH or even secondary PPH. Coagulation disorder is rare, but this can also be a cause. Uterine inversion is also rare. That is, during the delivery of the placenta, if somebody is not experienced enough and pulls the uterus or pulls the placenta, so what happens along with the placenta, the fundus of the uterus comes out of the vagina. So this happens in cases of home deliveries, or even sometimes the new doctors who starts having practice or going to delivery. So this can occur. That is rare. So once or twice a year we find women coming with uterine inversion. So that also lead to this is emergency, and the patient may be collapsed in this case. The management of all cases of obstetric hemorrhage is HELLP. You need immediate help, senior help, the help of the surrounding people like house officers, the RMOs, or the nursing staff, anesthetists. Then resuscitate the patient, replace and maintain blood volume. Of course, you will not be able to have availability of blood immediately, but you can replace it with a plasma. You can catheterize the patient, and then along with sending for the blood arrangement, you can investigate, send investigation, and try to find out, once you resuscitate the patient, try to find out the cause of the bleeding, whether it is due to placenta previa, it is due to placental rupture, or it is something else. And then there are certain maneuvers, there are certain medicines and drugs which erase the blood loss, like in case of uterine atonia, you can repeat the oxytocin, you can put cytotec. Then for the any genital trauma, you can immediately shift the patient to the OT and try to erase the blood loss by stitching the tear. Or in case of APH, you have to think of operative delivery. Amniotic fluid embolism is a rare condition, 1 in 30,000 pregnancy, occurs when amniotic fluid enters internal circulation. In our setup, it is very difficult to know or to think of amniotic fluid embolism in case of maternal collapse, because we don't go for autopsies, neither the pregnant woman is being autopsied. But in developed countries, this is also one of the causes of maternal collapse. Symptoms: the patient suddenly complains of severe chest pain and dyspnea, shortness of breath. Signs: we find the blood pressure lowers down, there is tachycardia, hemorrhage may be due to coagulation failure, pulmonary edema, the chest will be full of cramps, peripheral shutdown, and maybe she has seizures or secondary to hypoxia or cardiac arrest. Investigations: immediate force resuscitation, circulatory support, and shift patient to ICU. In investigation, we do ECG and coagulation profile, intubation, and 100% oxygen is given to the patient. And then according to the results of investigation, coagulopathy is treated aggressively. Acidosis is corrected, dopamine and steroids started, and this all has to be done. The patient should be shifted immediately to ICU. Pulmonary embolism is 3 per 1,000 pregnancies. 2/3 of cases occur in PARTUM, and it is one of the commonest cause of maternal death in UK. In our setup, the commonest cause of maternal morbidity and mortality is hemorrhage, and now the sepsis is also coming up. But in UK, the commonest cause of maternal death is pulmonary embolism. Here, the symptoms will be acute breathlessness, pleuritic chest pain, in more places, patient may vomit out with blood. Signs, of course, hypertension. The blood pressure will be low, tachycardia, patient will be immediately sinus, blue. Of course, patient has to need resuscitation, oxygen inhalation, and IV steroid. Along with that, certain investigations are required like ECG, X-ray chest, and ventilation, perfusion scan, which is not done in our setup. It's not available in our setup. So what you have to do, initiate a shift patient to the ICU care. Oxygen, at least oxygen inhalation is done. Maybe sometimes the patient needs intubation. And when you find that there is coagulation profile is disturbed, sometimes you need to go give her heparin 5,000 international followed by an infusion of 3,000 international over 24 hours. Now coming towards the hypertensive disorder, it complicates 5 to 7% of pregnancies. Preeclampsia is a disease of pregnancy which is characterized by a blood pressure of 140 by 90 millimeters of mercury or more on 2 separate occasions after the 20th week of pregnancy in a woman who was previously normotensive. So take note, see the definition is very important. This occurs after 20th week of pregnancy. If before pregnancy at 10 weeks or 15 weeks of pregnancy you find women with a high blood pressure, then she may be a chronic hypertensive. She may not have gone for checkup, or she may not be knowing about it, or she might have ignored it. So preeclampsia is always considered after the 20th week of pregnancy. And just on one findings, you cannot say that she's having preeclampsia. At least 2 findings, or 2 separate occasions, you have to take blood pressure 4 hours apart in a woman who, if she has been visiting to you, in which the blood pressure was normal. So when you find that the woman is having blood pressure, previously her blood pressure was 110 by 70 or 120 by 70, and this time she has come with 140 by 90 millimeters. So be alert. So then you have to at least either admit her in the daycare so that you can have 2 or 3 readings of high blood pressure. And along with that, you have to send certain investigations to confirm preeclampsia. So preeclampsia is accompanied by significant proteinuria that is greater than 300 milligram in 24 hours. Or even dipsticks can be done. That means the woman will give her urine sample, and by dipstick method you can check the albumin. This protein is plus, 2 plus, 1 plus, like this. That is the easiest method. For 24 hours urine, you have to give a jar in which the woman will collect her urine for 24 hours, and then you will check it and give it for the investigation. If the same woman, she develops high blood pressure and she throws a fit, then she will be called as having eclampsia. So eclampsia is the occurrence of conversion along with high blood pressure and proteinuria. Imminent eclampsia or fulminating preeclampsia is the transition condition characterized by increasing sinus symptoms. That means a woman may be having high blood pressure and suddenly she complains of headache, epigastric pain, blurring of vision. So be careful. She's having imminent eclampsia. If you do not treat her blood pressure, you do not control her blood pressure, she might throw fit. So imminent eclampsia is also dangerous, same like an eclampsia. It should be treated like eclampsia. Symptoms: frontal headache. The patient may be complaining of visual disturbances, headache, epigastric pain, restlessness, or in case of severe eclampsia or eclampsia, there may be signs of agitation, hyperreflexia, facial or peripheral edema, you might find that previously the patient was normal. Even the patient will tell you that I'm having swelling of the feet, I'm having swelling of the face. Whenever I get up in the morning, everybody notices swelling on the face. Right upper quadrant tenderness, that is on the liver side, and poor urine out. So in eclampsia, all the systems are involved. The CNS is involved because she might throw a fit. That means she may have cardiovascular accident. She might have blurring of vision, maybe sometimes blindness, epigastric pain, liver problem, liver involvement, liver capsule may be involved, then kidney may be involved. So this is a multi-organ system disease. Investigations: whole blood count to see the hemoglobin, the platelet count, clotting studies, that is the PTA, PTT, liver function test, serum uric acid to see the status of the kidney, renal function test, that is serum urea creatinine, urine, especially for protein, presence of protein, viral markers, we do it for everyone now. COVID test as well, blood group and RH vector, and random blood sugar. The management include three basic things. First of all, women having fits, control her fits, control conversions. Number two, your aim will be control her blood pressure, to lower down the blood pressure. And number three, you have to deliver her. So immediate resuscitation, followed by control of conversion by magnesium sulfate, control of blood pressure by hydrazine or labetalol infusion, and of course then you can delivering the patient, because until unless she's delivered, her blood pressure will not be controlled, because the main problem or the main issue or main pathology for preeclampsia is found in the placenta. Until unless the placenta is delivered, the patient will still be having her blood pressure on higher side. The treatment, the general treatment of eclampsia: turn the woman onto her side with head down so that she does not inhale the vomitus. Ensure the airway, because sometimes they bite their tongues. Many times when they come to emergency, they have already bitten their tongues, and the patient, the attendant will history, the patient was sitting and complaining of headache, and suddenly she fell down and threw a fit. So take care of her airway. Oxygen should be given, maintain IV line, catheterize the patient. The specific treatment of conversion is the 5 grams bolus of magnesium sulfate, IV slowly in 10 minutes. The total loading dose is 14 grams. So initially you will give 4 grams of bolus magnesium sulfate IV in 10 minutes, followed by 5 grams in each buttocks, and then the maintenance dose. The blood pressure is lowered down with hydrazine or labetalol, and then you have to decide once the patient is out of emergency or stable, then you can think of the timing of the delivery. Timing as well as the mode of the delivery. So most of these patients are multis, so sometimes they do deliver normally once the blood pressure is controlled, but you find that she's continuously fit and she's going into, she's losing her consciousness, then expect her to go for the cesarean delivery. Indication for urgent delivery: persistently high blood pressure, 160 by 100 millimeters of mercury or more, with significant proteinuria, elevated liver enzymes, low platelets, and urea, no urine output, fit, eclamptic fit, or significant fetal distress. HELLP syndrome occurs in 5 to 10% of cases of severe preeclampsia, and it is a combination of H is for hemolysis, E, L is elevated liver enzymes, and low platelet count. So when you send these investigation of these patients, you find that LDH is raised, the liver enzymes are disturbed, the platelets are low, along with the high blood pressure. Even sometimes a patient may be normal cancer, but the investigation will be showing hemolysis, elevated liver enzyme, and low platelets. So think always of HELLP syndrome, because this is a serious condition with significant fetal and maternal morbidity and mortality, and is associated with disseminated intravascular coagulation, abruption, and fetal death. HELLP syndrome. Now, also collapsed obstetric patients. So let's talk about the normal. A woman has come to you with an emergency in a collapsed condition and she's pregnant. So what do you think of? Simple pain. Always start with a normal thing, because maybe due to hot weather, maybe she has not eaten anything, maybe she has been vomiting and she has fainted. Number 2, take history of epilepsy. Hypoglycemia, yes, sometimes the woman is having excessive nausea, excessive vomiting, hyperemesis gravidarum. So they do not eat anything. They are not given proper food or proper fluid, so they also have hypoglycemia. Profound hypoxia due to any reason. Think of intracerebral bleed. Maybe she had a history of fall. Take history of fall. Take history of blood pressure, cerebral infarction, cardiac arrhythmias. Take history of cardiac involvement. Many patients, they come to us and they don't know that they have some cardiac problem, because throughout they have been all right, but with the pregnancy, they start having arrhythmias, or maybe the cardiac factors is picked up. Pulmonary embolism, anaphylaxis. Anaphylaxis can occur with any drug. Septic shock, hemorrhage with talk, eclampsia, allostatic problem, amniotic fluid embolism, and uterine inversion. Now so this was all about the maternal emergencies, right? The blood loss, the APH, PPH, the embolism, pulmonary embolism, amniotic fluid embolism, eclampsia, and all the causes of obstetric collapse. It's not only that these causes may be the cause of obstetric collapse, maybe simple faint, or maybe she had history of some fall, something else. So you always have to take proper history. Proper history from the attendants is very important. Fetal emergencies include umbilical cord accidents and shoulder distortion. Umbilical cord accidents, the incidence is 1 in 500. It can be either cord presentation or cord prolapse. The difference, what is the difference between cord presentation and prolapse? In case of cord presentation, the membranes are intact, but you can feel loops of umbilical cord, something very soft below the presenting part, and the membranes are intact. So when you do examination, you find that you can feel something, some pulsation, soft thing. This only occurs, can be picked up with experience. So this is called cord presentation. So that means anytime the membranes rupture, the cord will come out. If the membranes get ruptured, then it will be cord collapse. That means cord comes out of the cervix or vulva. Sometimes the patient comes in emergency with cord hanging outside the vulva. And when you take history, they will say that there was a gush of fluid, and then suddenly we feel something soft coming out. So this is a real emergency. And if it occurs in your setup, in labor room, by doing in the ARM, if you do artificial rupture membrane on high head, this can occur. So be careful, never try to do ARM on high head. Until unless the head is fixed, please do not do that. So because then once the membranes are ruptured and cord comes out, then it is the emergency. The causes of cord collapse may be premature baby, malpresentation, maybe transverse lie, maybe breech presentation, and the cord comes easily outside. Twin pregnancy, polyhydramnios. Polyhydramnios means excessive liquor. So whenever there is excessive liquor, the baby keeps on moving. So the presentation may be malpresentation, unstable lie. We have to be very careful going for the delivery for these patients, because whenever there is excessive liquor, the fetus may not be in proper position, it may be in malpresentation, and the cord may come out. The management, in case of cord prolapse, if the fetal heart sounds are present, urgent cesarean section is done until unless the cervix is fully dilated. So whenever cord prolapse occurs, you have to see two things: presence of fetal heart sound and the cervical dilatation. If the patient is fully dilated, immediately deliver her by some instruments, a vacuum or by forceps. Or if you find that she's only 4 or 5 centimeters and the cord pulse is there, number one, you have to relieve pressure on like the vein by placing mother in head down position. All fours with the hips elevated. That means try to push the cord inside the uterus, inside the vagina, and relieve the pressure on it, and fill bladder with 500 of normal saline to displace the presenting part upward. Because if the presenting part is pushing in or pressing the umbilicus, the blood flow will be destroyed, will be disrupted, and the baby may die immediately. So the first thing is relieve pressure. Number 2, fill bladder with 500 ml of saline to displace the presenting part upward. And immediately take patient for the cesarean section of the baby's anatomy. Shoulder dystocia is a real emergency. May occur in 0.2 to 1.2% of cases. Alarming occurrence. That means a real emergency. You're delivering a patient and find that the shoulders are stuck. So what happens? The baby's head come out and you're unable to deliver the fetal's shoulders. So that is also called turtle sign, like a turtle, and you cannot even pull it. It's very difficult. So that's why we always advise that the woman in the labor room should be done every 3 months. Drills should be done so that the staff over there should be able to identify the shoulder dystocia and would be able to handle it, because it's a few minutes time when you have to do it. Otherwise, the baby. The risk factors may be large baby in cases of uncontrolled diabetes, maybe grand multi, small mother, big baby, maternal obesity, again diabetes, uncontrolled sugar may lead to macrosomia of the baby. Post-mature baby will be having good signs of prolonged second stage of labor. So always try to find out the risk factors. And if you find in your antenatal that the patient is having, there's a risk of shoulder dystocia, or there's a risk of baby delivering with difficulty, or shoulder may start because of the good size of the baby, because you can assess the fetal weight by ultrasound and by doing abdominal examination. Or if a woman is having any risk factor. So try to counsel the woman every day and try to decide the moment. Better counsel her, tell her the complications, tell her this can occur immediately, and even sometimes you may not be there. The junior staff is there. Sometimes this happens. Better counsel her, and if you think that this baby might end up with complications, it's better to go for cesarean section rather than giving a risk of shoulder dystocia in these moments. The management. So there are certain maneuvers by which you can deliver this baby, but it's really hard. Again, as I said, if antenatal booking, you find that the baby seems to be good size, more than 2.5 kg, better decide for cesarean section rather than normal delivery as the mode of delivery. Number 2, shoulder dystocia drill should be carried out every 3 months in the labor room or the junior staff. The first thing will be call for help. As soon as you find that the baby's head is delivered, but you are unable to deliver the shoulder, call for the help. Avoid excess traction on the head. Hyperflex and abduct the hips. This is called macrobics position. Hyperflexion and abduction of hips will also help to distort the shoulder, because in these cases what happens, the shoulders, they are not engaged properly. So Apply suprapubic pressure to dislodge the shoulder which is stuck. Rotate the shoulder by internal manipulation and then deliver the posterior arm. So there are certain maneuvers for shoulder dystocia. By this, most of the time, the first two maneuvers, that is McRoberts position and by applying suprapubic, not the fundal pressure, the patient delivers. But still, sometimes you might have a problem. You might fail by doing these two maneuvers. Then the third will be internal manipulation, that you put your hand, take your hand inside and deliver the posterior arm. So any woman, you think the baby seems to be good size, or you anticipate that she might end up with a problem, it's better to give episiotomy so that you have enough space, you have enough place to put your hand inside, to take your hand inside. Avoid fundal pressure, turning the patient into left lateral position, inappropriate traction of the head. So this should be avoided. Putting by pulling the head of the baby will not solve the problem. Once you identify this as shoulder dystocia, call for the help, make Roberts position, stop fundal pressure, apply suprapubic pressure, put your hand inside and try to dislodge the posterior arm. Once the posterior arm is dislodged, the baby will deliver. Thank you very much. So this was all about the emergencies, and this has been taken from the references. This is taken from the 10 teachers, Ops 10 teacher, the latest edition. Very interesting, I think, topic, and please read it. And if you have any queries, any questions, you can ask me. Although it seems to be a big chapter, I won't be able to tell you each and every management, but still I try to make it short so that you can pick up, at least you should be knowing what is emergency and what are the main cause of maternal collapse. At least you can be understanding all these things, especially when you come in a ward. You'll go in the ward, you'll be able to understand these obstetric emergencies better. So any questions? Any questions?
मैडम अभी तक कोई क्वेश्चन नहीं है.
Okay, मैं इंतजार कर रही हूँ. We still have time.
जी सर. जी मैडम.